Good morning. Today we are going to discuss about the mechanism of action of hypoglycemic agent. Now, we know that already we have discussed what is diabetes mellitus. It is a disorder characterized by the hyperglycemia due to the uh, abnormal metabolism of the carbohydrate, protein and the fat. And it is mainly four type: type 1 insulin dependent, type 2 non-insulin dependent, gestational diabetes mellitus, which is occurs mainly into the pregnancy, and other special type. And already we have discussed what is the pathogenesis involved in the type 1 and type 2 diabetes mellitus. Now we know that already this insulin, glucagon, and other pancreatic hormones also it was discussed. So directly we are going to start with the oral hypoglycemic agent. Now this is the different pharmacological treatment available for the management of diabetes mellitus. So there are the different injectable agents like insulin, amylin analog, glucagon like peptide analog, and under the oral hypoglycemic agent sulfonylurea first generation and second generation, tolbutamide under the first generation, glucoside under the second generation. Next is the meglitinides, that is the nataglinine, biguanide, metformin. Next is thiazolidine dione, that is the rosiglitazone, PPAR alpha and gamma agonist, saroglitazar, alpha glucoside inhibitor, acarbose, DPP4 inhibitor, that is the sitagliptin, LGLT2 inhibitor, these are the dopagliflozin. Now coming to the mechanism for the sulfonylurea and meglitinide. Now this is the beta cell. This is the beta cell. Now as we know that in the beta cell there is a potassium channels are there. Now this potassium channel it is known as the KATP channel because opening of this channel it is mainly triggered due to the ATP. ATP is the triggering source for the opening of this potassium channel. And here we can find that sodium potassium ATP it is there, calcium channels are there. Now what will happen in the normal cases, glucose it will enter into the pancreatic beta cell through the GLUT2, and there it will undergo the metabolism using the glucokinase type of and other enzymes, and due to this metabolism ATP it will be synthesizing, and it is the triggering force for the opening of the potassium ATP channel. And glucose, after the glucose metabolism, proinsulin biosynthesis it will take place. Proinsulin again it will convert into the insulin, then it will stored into the granules, and whenever there is a exocytosis this insulin it will be released, normal case. Now sulfonylurea it will bind to its specific receptor which is located into the potassium channel. This is the area where the sulfonylurea it will bind, sulfonylurea receptor 1. Now sulfonylurea what they will do, they will bind to the sulfonylurea 1 receptor, and they are going to block this channel, block this potassium channel. Now if the potassium channel it will block, what will happen? Potassium it will not go outside, and if it is not go outside, that means what happens, it will cause the depolarization, because we know that if the positively charged ion go outside, normal action potential it will cause the hyperpolarization. Now potassium channel is blocked, so it will cause the depolarization. Now due to the depolarization it will cause the opening of the calcium channel. It will cause the opening of the calcium channel. Now calcium it will be open. After the opening of the calcium channel it will cause the exocytosis. It will act on the insulin, and due to the exocytosis insulin it will be released. So sulfonylurea it will bind to its sulfonylurea 1 receptor which is located on the potassium channel. Potassium channel it will be blocked. It will cause the depolarization, so that calcium channel it will open. Calcium it will concentration of the calcium in the inside the cell it will increase. As a result it will cause the release of the insulin. Now so sulfonylurea it is increase the release of the insulin. Meglitinide also using the same mechanism, only with the minor difference, it will bind to the another side. It will not bind to the sulfonylurea receptor, but it will bind to the another side of the potassium channel, but other mechanism is completely same. So both these two category of the drug is act by the increasing the insulin release. Now under the biguanides, it only the drug which is under the market. Metformin is there. Metformin, it is not available, it is withdrawn from the market. Now metformin, it will not going to enhance the release of the insulin. Right? It is not going to enhance the release of the insulin. How they are going to act? Metformin in the hypothalamus, it will cause the inhibition of AMPK. That means adenosine 5 monophosphate activated protein kinase. It will cause the inhibition of AMPK. Whenever the AMPK it will be inhibited, neuropeptide it will be decreased, then food intake and body weight it will be reduced. In case of the liver, it will cause the activation. Liver and muscle, it will cause the activation of AMPK. So this is the opposite what it is shown into the hypothalamus. So in liver, it will cause the activation of AMPK, so that ACC, acetyl coenzyme carboxylase, and HMG CoA it will be reduced. ACRB, that is the sterile regulatory element binding protein, it will be reduced. Their expression and activity it will be reduced. As a result, fatty acid synthesis it will be reduced, so that fatty acid activation it will be increased, but fatty acid synthesis and cholesterol synthesis it will be inhibited. So as a result, it will cause the liver insulin sensitivity. That means resistance. It is the main problem with the type 2 diabetes. Now insulin sensitivity it will be enhanced by the biguanides. And also you can say that you can find that it is also increasing the SRET1, then PEPCK, then glucose 6-phosphate dehydrogenase, fructose 1,6 biphosphate, so that gluconeogenesis in the liver also it is reducing. In the muscle, it will cause again the activation of AMPK, glucose uptake, glycogenesis, and oxidative utilization of glucose it will be increased. So whenever biguanides it is acting, it is act like that of the insulin. Insulin also, whenever we have discussed, we have seen this type of the effect. So in the insulin also, the biguanide having the similar type of the effect. Clear? Biguanides having the similar type of the effect like that of the insulin. It is increasing the insulin sensitivity, it is increasing the glucose uptake, glyconeogenesis it will be increased, but gluconeogenesis it will be reducing. Next is thiazolidine dione. Now in case of the thiazolidine dione, here it is important the role of the peroxisome proliferated activated receptor gamma. It is the nuclear hormone type of the receptor, and retinoid X receptor also it is there. Retinoid X receptor also it is present. Now what will happen to this particular cases, PPAR, there the different types of the PPAR is present. Like PPAR alpha, it is expressed into the liver, kidney, brown adipose tissue, skeletal muscle, etc. Gamma, adipose tissue, muscle, kidney, colon, pancreas, liver, intestine. Then delta, found in brain, adipose tissue, skin, etc. Now what will happen, if you see about this gamma is expressed into the pancreas. Now thiazolidine, when it will we are going to give the thiazolidine, it will act on the PPAR gamma, and then that is retinoid X receptor also it will be combined, and we know that this is the nuclear receptor. Receptor is 4 type, and G protein, ligand gated, kinase link, and nuclear. And this nuclear is the only receptor which present inside the nucleus. And already you know that how the nuclear receptor is acting. After binding, it will bind into the DNA. Dimerization it will take place. Transcription, mRNA synthesis, it will bind with the ribosome, and then specific protein it will synthesis. And if you see about their action, in that different tissue, adipose tissue increase glucose uptake, increase fatty acid uptake, lipogenesis, adipocyte differentiation, decrease lipolysis, decrease TNF alpha and leptin, increase adiponectin. So TNF alpha, leptin, these are the biomarkers. So these are the increasing, and this is also having the important role into the glucose metabolism. In liver, decrease gluconeogenesis, decrease glycogenolysis, increase lipogenesis and glucose uptake. So all those things, it is helpful actually maintaining the blood glucose level. Muscle, again, they are increasing the insulin sensitivity, increase glucose uptake, increase glycolysis, increase oxidation and glycogenesis. Again, all these effects are, you can say that, in the direction either the increasing the insulin sensitivity or increase the glucose uptake towards the muscle or towards the fat cell, increase the glycogen synthesis or reducing the glucose synthesis. So all those things, it is related to their effect. Now coming to the alpha glucosidase inhibitor. Now in our you can say that intestine brush border, there is a different types of the enzymes are there, like alpha glucosidase, alpha amylase. They are involved into the breakdown of the food to the glucose. Now here we are shown that oligosaccharide, after taking the food, oligosaccharide, it will break down into the monosaccharide, that means in the glucose, to the alpha glucosidase, so that after food, post prandial glucose level, it will be increasing. So it is increasing the post prandial glucose. So this glucosidase, it will helpful to breakdown of the oligosaccharide to monosaccharide. But whenever we are giving the alpha glucosidase inhibitor like acarbose, they will block this enzyme. Clear? If they will block this enzyme, glucose production will not there. Actually, it is not like that it will completely stop, but it will be slow down. Right? It will be slow down. If it is slow down, then suddenly after the food, blood sugar, it will not increase. So what does it mean? The enzyme responsible for the breakdown of oligosaccharide to monosaccharide, we are preventing that. So slowly their production of the glucose, so blood glucose, it will not instantly increase after the consumption of the food. Next is DPP4 inhibitor. Now first one is the GLP1. GLP1, what is the function of the GLP1? GLP1 is the glucagon like peptide 1 in the pancreas. Increase the glycogen, decrease the glycogen secretion. Glycogen involved for responsible for the increase into the glucose level. Increase the insulin release. Reduce the beta cell apoptosis, or is increasing the beta cell mass. So that means they are the helpful to maintain of blood glucose level. In case of the liver, adipose tissue, muscle, increase the glucose uptake and increase the glycogen synthesis. Again, liver, fatty acid synthesis and oxidation, which is reduced. Now these effects is mainly we can correlate with the regulation of the glucose by GLP. Now after the intake of the food, body is secreting more amount of the GLP and GIP, that is the glucose dependent insulinotropic polypeptide. Now what will happen? DPP4, another enzyme, that is the dipeptide, that is dipeptidyl peptidase 4. What they do, they will cause the breakdown, inactivation of the GLP. Inactivation of the GLP means this pancreatic function in the liver, adipose tissue, muscle tissue, it will be inhibited. Now if we can inhibit this one, then what will happen? More quantity of the GLP, it will be available. More quantity of the GLP is available means that the functions, it will be there. That means they are able to control the blood glucose level. Blood glucose level, it will be less. So this is the mechanism of action of DPP4 inhibitor in short. So this is the function of the DPP4 inhibitor. So if any doubt, we can discuss it again. And last class of the drug is the LGLT2 inhibitor. Now whenever there is you can say that through kidney urine formation is there. Now through the glomerulus formation, a large proportion of the water glucose it will be absorbed inside the nephron. But again, more than 90% or the 95% of this water glucose again it will be transported into the blood. That means it is again it will, you can say that, enter into the blood. Clear? Now what will happen? Who is responsible for this transportation? That means lumen to blood. Clear? Lumen to blood. So it is nothing but it is a reabsorption process. Clear? Reabsorption process. Now here LGLT2 and LGLT1, these are the two transporter it is available. LGLT2 is present into the proximal tubule part S1 segment and LGLT1 in the S2 and S3 segment. But LGLT2 is mainly responsible for the transportation of glucose. Now it is, if you see that it is a co-transporter, so glucose and sodium it will come inside, and then again you can say that glucose and through the sodium potassium pump, sodium it will enter into the blood. So it is the inside the urine, inside the nephron, and then it is again reabsorbed in the blood. Now LGLT2 inhibitor, they are going to act on here, they are going to inhibit one. This is the main transporter compared to LGLT1. LGLT2 is the main transporter, clear? Main transporter. So it will block here. If it is blocked, what will happen? Glucose it will not able to reabsorb, clear? It will not going to absorb, and it will eliminate through the urine, clear? It is eliminate through the urine because it is inhibiting this transporter LGLT2. So glucose cannot go inside the blood, it will not reabsorb, otherwise it will be come out through the urine. So if the body having the more glucose, it will come out through the urine, and in the blood glucose level it will be normal, right? It will be maintained. So that is the mechanism of the SGLT2 inhibitor. So these are the defined drugs are there. In the next class we will see about their specific side effect, interaction and other things. We'll see. So this is the source of this figure. Thank you.